Hi there. My name is Barbara Hamilton, and I'm an interventional radiologist in the Southern California desert. I am chief of my section at Desert Regional Medical Center, and I gave this talk on trauma in the community to a group of young and aspiring interventional radiologists at a conference last month, February of 2020, in Los Angeles, in Santa Monica, at a conference called WINGS. It's Western Interventional Next Gen Symposium. So check that out if you ever have a chance. I wanted to include my Twitter handle here in case you'd like to follow me there. Sometimes I share cases, but it's also just some advocacy for women in IR and also about financial empowerment topics. So to get started with this talk, I wanted to highlight an article in Press. It's a white paper from the Society of Interventional Radiology talking about the evidence that we have for a lot of the things we do for patients with solid organ injury. So although it's a difficult patient population to study, there is this great paper coming out which sums up a lot of the evidence for the things that we do for our trauma patients. And one of the co-authors is my illustrious mentor, John Moriarty, who I trained under at UCLA. So with that, I'll share some of the cases for what I've seen as far as trauma in the community. This was a 19-year-old woman who presented on Thanksgiving Eve with a stab wound to her left parasternal border, and at an outside institution, she got this CT, which demonstrated a large anterior mediastinal hematoma. And on the left-sided image, you can see there's attenuation of the internal mammary artery, compatible with an arterial injury. So her heart rate was increasing at 110 beats per minute, and her blood pressure was still in the normotensive range. And I was asked to help by the cardiothoracic surgeon. So I took a right femoral artery approach, and I accessed the left internal mammary artery using a catheter, as you see here. And I wasn't sure if I'd be able to cross the area of injury. And as you know, there's collateralization, collateral flow from the inferior epigastric artery to this location. So thankfully, I was able to image the artery. It looked like just a site of spasm with no active extravasation at the time I was imaging. And I treated using a coil pack distal and proximal to the site of injury. And so that patient did well. My next patient was a 40-something-year-old female who presented after being in a small aircraft crash south of the Salton Sea, and she was brought in with a systolic blood pressure that was crashing from the 80s to the 40s. And she had a number of injuries, some axial load with some spinal fractures, and I was asked to see her. This CT demonstrates a tiny focus of contrast extravasation, which you can see on the right side of the hemipelvis. It's very subtle, and just a tiny focus of extravasation near the posterior right acetabulum, basically. And due to the hemodynamic instability, I was asked to see her. So I took her for a pelvic angiogram. And here you can see a nice example of what non-hypertrophic uterine arteries look like. These little squiggly arteries in the center of the pelvis are an example of non-hypertrophic uterine arteries. And so in any case, this is a trauma case. So I did a pelvic angiogram. I didn't see any active extravasation. And when you don't see active extravasation, you can go more selective to be more sensitive for extravasation. That's what I did in this case. I selected the ipsilateral right internal iliac artery and still didn't see any extravasation. So given her, she had some sacral fractures and it wasn't clear where the bleeding was from, I just did a gel foam embolization, including the anterior and posterior divisions of the right internal iliac artery. And she stabilized and eventually was able to leave the hospital. My next case was a 29-year-old male shot with a shotgun. And you can see here he was found to have sacral fractures and innumerable ballistic fragments retained in the pelvis. And there was a site of active contrast extravasation in the left hemipelvis there. You can see it in the center of the hematoma. And initially he was normotensive and with a heart rate of 64. But by the time I took him for angiography, here you can see a characteristic appearance on the pelvic angiogram. These elongated, thinned out arteries are that way because of diffuse vasospasm. So this is actually a shock angiogram, shock appearance. And you can see those retained ballistic fragments. And over the course of the same angiogram, you can see development of active extravasation arising from the anterior division of the left internal iliac artery. And so I treated that with gel foam embolization. And I included the posterior division of the left internal iliac also due to the extensive soft tissue and gluteal injury present. And that patient did well. My next patient was a 69-year-old male who fell from a ladder, and this is a gentleman who proves that you don't always have to be young and healthy to be a trauma patient. This gentleman had a history of lymphoma, pancreatic cancer resection, and somehow found himself cleaning off a dusty roof when this happened. So, also a history of cabbage. By the time I was asked to see him, his blood pressure was dipping into the 80s over 50s. His heart rate was still within normal range. And here you see his CT, which demonstrates active extravasation arising in the low left hemipelvis due to a pubic ramus fracture. So here's his angiogram, which is compatible with his known comorbidities. He had a cabbage, many years of history of hypertension, and he had these tortuous iliac arteries and a steep aortic bifurcation, which can present a technical challenge when you're going in to operate on these patients endovascularly. Over the course of the angiogram, you see development of active extravasation low in the hemipelvis, just to the left of midline, kind of posterior to the pubic symphysis. And I was able to cross the bifurcation with some effort, and the 5 French catheter went right into this branch, supplying the area of extravasation. And with the help of a microcatheter, I was able to cross that artery where the injury was arising. There you can see the extravasated contrast sitting in the pelvis, and my coil pack as I coiled across the defect. You can also see in the right hemipelvis, that's the bladder, which is decompressed with a Foley catheter in it and some contrast from the iodinated contrast we're giving. And the bladder is displaced to the right of midline by the pelvic hematoma. My next case was a 61-year-old male in a motorcycle crash, and I was asked to see him after we discovered that a chest tube was placed ectopically. Patient presented with just trace pneumothoraces and underwent surgical chest tube placement at the bedside, but unfortunately the chest tube didn't go into the right place. So here you can see a coronal reformatted image demonstrating a chest tube located in the central liver. And the CT didn't demonstrate any extravasation or active hemorrhage. It didn't show any pseudoaneurysm or anything like that. But in coordinating with the trauma team, we were able to do an angiogram. I selected the right hepatic artery and did an angiogram prior to and following removal of that chest tube with the surgeons in the angio suite. And so we were able to see that there was no evidence of arterial injury before or after the chest tube was removed. So this just demonstrates how we can optimize care by coordinating well with the trauma surgeons. And this was a great way to optimize care for this patient. And he did well. My next case was a motor vehicle crash patient. This gentleman had a finding that we don't see every day. And you can see here in the left hemithorax that he actually had active extravasation into the pleural space on the CT. And as you know, the chest cavity can accumulate blood quite rapidly. So this is a place where there's no way to tamponade the bleeding and a patient can exsanguinate pretty quickly. So I was asked to see him. And here you can see I was able to quickly cannulate the appropriate intercostal artery just using the displaced rib fractures at the adjacent level as anatomic landmarks, which you can faintly see the displaced fractures here. And I didn't see any active extravasation, so I did an empiric gel foam and coil embolization of the appropriate intercostal artery. And that patient stopped bleeding. His chest tube output decreased after that and then stopped. My next example was a 17-year-old male with a gunshot wound to the perineum. So he heard his brother fighting in the yard with a neighbor and decided to go help. He ended up with a gunshot wound to the left hip and through the base of the penis, basically. And CT demonstrated active extravasation in the perineum as well as around the Foley catheter, concerning for a urethral injury. The patient was taken to the operating room by the trauma surgeons, and they tried to stop the bleeding there, but they were not successful. So they asked me to help with this case. So here you have again that elongated, spindly appearance of the arteries. This is an image with the left internal iliac artery selected, and you can see that there's reflux of contrast into the external iliac artery due to the diffuse vasospasm. And you can see the retained ballistic fragment there overlying the left external iliac artery. And over the course of the angiogram, you can see the active extravasation into the perineum. And this was even more prominent on the right side, where you can see frank extravasation into the enlarged scrotum and base of the penis. And although there is a normal penile blush that you can see on angiography, this is flagrant and corresponds to clinical bleeding. So given the location of the injury, I did gel foam embolization of each anterior division of each internal iliac artery. And the bleeding stopped. My next patient was driving 70 miles an hour in his sports car when he fell asleep at the wheel. And he presented normotensive with a slightly elevated heart rate. His CT demonstrated a splenic fracture with high-density perisplenic free fluid. And on the left-sided image, you can see just a little tiny focus of extravasation arising from the medial lower part of the spleen. So I was asked to see this patient. I did a selective arteriogram of the splenic artery, and that demonstrated rapid extravasation into the peritoneum from that lower pole splenic region. And the delayed image demonstrates the irregularity of the splenic blush from the splenic fracture itself. And so there are a couple ways to embolize a spleen in the setting of trauma, proximal or distal. And so because I was able to see the extravasation, I could do a distal splenic embolization targeting the specific artery supplying the bleed. And here you can see that. With the help of a microcatheter, I was able to select the specific branch supplying the area of bleeding and use a combination of gel foam and microcoils to make the bleeding stop. And there in the left upper quadrant, you can see remnants of that extravasated contrast from the previous run. My final patient was stabbed in the back and wasn't feeling well, so was brought into the emergency room a few hours later by his family. And CT demonstrated this large perinephric hematoma with a huge pseudoaneurysm in the middle of the right kidney, and he was becoming hypotensive, so they were resuscitating him at the time. Coronal reformatted images demonstrated that there were two right renal arteries. And so since the pseudoaneurysm was arising from the upper pole of the kidney, I was most suspicious in planning my angiogram that the problem would be arising from that upper pole renal artery. And so here's the angiogram where I selected that upper pole renal artery, and indeed that turned out to be supplying the abnormality. Here you can see that there's a rapid filling of that large pseudoaneurysm with early filling of the draining renal vein and the IVC. So this is compatible with a pseudoaneurysm with a traumatic AV fistula. So I coiled the main branch I thought was supplying that pseudoaneurysm and did a follow-up angiogram using my catheter here. Looked like there was still early filling of the renal vein. So I interrogated using a microcatheter that adjacent artery. And indeed, that was the offending area where there was still a traumatic AVF arising from that branch. And so I treated that with coil embolization. And this is my follow-up angiogram demonstrating no persistent filling of that pseudoaneurysm and no residual early venous filling. So this patient gets to keep his kidney. And here you see a nice example of renal artery spasm. This can be seen just with a power injection or sometimes just with wire or catheter manipulation. So clearly this wasn't here before, so it's not fibromuscular dysplasia. This is just renal artery spasm and a nice example that you'll see. Finally, I'll leave you with this paper. It's tips and tricks for the trauma patient that came out of the one of the Army medical centers in Texas, and a nice paper which describes how you can build the relationship with your trauma surgeons if you don't already have that relationship well established. And I thought it had some nice ideas that we weren't even using at this point, despite having a really good relationship and communication back and forth. Here are my references. And thank you so much. You can find me at Superheroine on Twitter. You can feel free to shoot me any questions by email, tiredsuperheroine at gmail.com. And I also blog about work-life balance and financial empowerment when I'm doing these trauma cases and all kinds of other crazy things in interventional radiology. And so that's at tiredsuperheroine.com. Thanks so much.